Monkeypox is a viral zoonosis with symptoms similar to those seen in the past in smallpox patients, although it is clinically less severe due to the eradication of smallpox in 1980 and subsequent cessation or stopping of smallpox vaccination. Monkeypox has emerged as the most important orthopox virus for public health. Monkeypox primarily occurs in Central and West Africa, often in proximity to tropical rainforests, and has been increasingly appearing in urban areas. Monkeypox virus is an enveloped double-stranded DNA virus that belongs to the orthopox virus genus of the Poxviridae family. There are two distinct genetic clades of the monkeypox virus: the Central African clade and the West African clade. The Central African clade, also known as Congo Basin clade, has historically caused more severe disease and was thought to be more transmissible. Cameroon is the only country where both virus clades have been found. Various animal species have been identified as susceptible to the monkeypox virus. This includes rope squirrels, tree squirrels, Gambian pouched rats, dormice, non-human primates, and other species. Uncertainty remains on the natural history of the monkeypox virus, and further studies are needed to identify the exact reservoir and how virus circulation is maintained in nature. Human monkeypox was first identified in humans in 1970 in the Democratic Republic of the Congo in a 9-month-old boy in a region where smallpox had been eliminated in 1968. Since then, most human cases have increasingly been reported from across Central and West Africa. From 1996 to 97, an outbreak was reported in the Democratic Republic of the Congo with a lower case fatality ratio and a higher attack rate than usual. Since 2017, Nigeria has experienced a large outbreak, with over 500 suspected cases and over 200 confirmed cases, and a case fatality ratio of approximately 3%. Cases continue to be reported until today. Monkeypox is a disease of global public health importance, as it not only affects countries in West and Central Africa, but the rest of the world. In 2003, the first monkeypox outbreak outside of Africa was in the United States of America and was linked to contact with infected pet prairie dogs. These pets had been housed with Gambian pouched rats and dormice that had been imported into the country from Ghana. This outbreak led to over 70 cases of monkeypox in the United States. It has also been reported in various parts of the world like the United Kingdom, United States, Singapore, etc. in travelers from Nigeria in 2018, 2019, 2021, and 2022. In May 2022, multiple cases of monkeypox were identified in several non-endemic countries. Animal-to-human transmission can occur from direct contact with the blood, bodily fluids, or cutaneous or mucosal lesions of infected animals. Some people eat meat of monkeys, rats, and squirrels. Eating such ill-suited or inappropriate infected meat and other animal products of infected animals is a possible risk factor. Human-to-human transmission can result from close contact with respiratory secretions, skin lesions of an infected person, or, recently, contaminated objects, or things like clothes, towels, and bedding. Transmission via droplet respiratory particles usually requires prolonged face-to-face contact, which puts health workers, household members, and other close contacts of active cases at greater risk. Transmission can also occur via the placenta from mother to fetus, which can lead to congenital monkeypox, or during close contact, during and after birth. Close physical contact is a well-known Risk factor. Recently, human-to-animal transmission was seen. A pet dog has been infected with monkeypox after catching the virus from its owner. It is the first ever case of its kind. The incubation period, the interval from infection to onset of symptoms of monkeypox, is usually from 6 to 13 days, but can range from 5 to 21 days. The infection can be divided into two periods. The invasion period, which lasts between 0 to 5 days, is characterized by fever, intense headache, lymphadenopathy, swelling of the lymph nodes, back pain, myalgia, muscle aches, and intense asthenia, lack of energy. Lymphadenopathy is a distinctive feature of monkeypox compared to other diseases that may initially appear similar. The skin eruption usually begins within 1 to 3 days of the appearance of fever. The rash tends to be more concentrated on the face and extremities rather than on the trunk. It affects the face in 95% of cases, palms of the hands, and soles of the feet in 75% of cases. Also affected are oral mucous membranes, in 70% of cases, genitalia in 30% of cases, conjunctiva in 20%, as well as cornea. The rash evolves sequentially from macules that are lesions with a flat base, to papules that are slightly raised firm lesions, vesicle that are lesions filled with clear fluid, pustules that are lesions filled with yellowish fluid, and crusts which dry up and fall off. The number of lesions varies from a few to several thousand. In severe cases, lesions can coalesce until large sections of skin slough off. Monkeypox is usually a self-limited disease, with symptoms lasting from 2 to 4 weeks. Severe cases occur more commonly among children and are related to the extent of virus exposure, patient health status, and nature of complications. Underlying immune deficiencies may lead to worse outcomes. Complications of monkeypox can include secondary infections, bronchopneumonia, sepsis, encephalitis, and infection of the cornea with ensuing loss of vision. The extent to which asymptomatic infection may occur is unknown. The case fatality ratio of monkeypox has historically ranged from 0 to 11% in the general population and has been higher among young children. In recent times, the case fatality ratio has been around 3 to 6%. Polymerase chain reaction is the preferred laboratory test, given its accuracy and sensitivity. For this, optimal diagnostic samples for monkeypox are from skin lesions, the roof or fluid from vesicles and pustules, and dry crusts. Clinical care for monkeypox should be fully optimized to alleviate symptoms, manage complications, and prevent long-term sequelae. Patients should be offered fluids and food to maintain adequate nutritional status. Secondary bacterial infections should be treated as indicated. An antiviral agent known as tecovirimat, or T-pox, that was developed for smallpox was licensed by the European Medicines Agency for monkeypox in 2022, based on data in animal and human studies. But it is not yet widely available. If used for patient care, tecovirimat should ideally be monitored in a clinical research context with prospective data collection. Raising awareness of risk factors and educating people about the measures they can take to reduce exposure to the virus is the main prevention strategy for monkeypox. Scientific studies are now underway to assess the feasibility and appropriateness of vaccination for the prevention and control of monkeypox. Some countries have developed or are developing policies to offer vaccine to persons who may be at risk, such as laboratory personnel, rapid response teams, and health workers. Vaccination against smallpox was demonstrated through several observational studies to be about 85% effective in preventing monkeypox. Thus, prior smallpox vaccination may result in milder illness. Evidence of prior vaccination against smallpox can usually be found as a scar on the upper arm. At the present time, the original smallpox vaccines are no longer available to the general public. Some laboratory personnel or health workers may have received a more recent smallpox vaccine to protect them in the event of exposure to orthopox viruses in the workplace. A still newer vaccine was approved for the prevention of monkeypox in 2019. This is a two-dose vaccine for which availability remains limited, reducing the risk of human-to-human transmission. Surveillance and rapid identification of new cases. Isolation of infected individuals. Standard infection control precautions should be taken while handling patients and specimens. Health workers previously vaccinated against smallpox should be selected for patients' care. Only trained staff should handle test samples. Reducing the risk of zoonotic transmission. Avoid direct contact with wild animals, especially those that are sick or dead. Restrictions should be imposed on the animal trade. Isolation and immediate quarantine of infected animals. Quarantine and observation of suspected animals for 30 days must be done to reduce the transmission. The clinical presentation of monkeypox resembles that of smallpox, a related orthopox virus infection, which has been eradicated. Smallpox was more easily transmitted and more often fatal, as about 30% of patients died. The last case of naturally acquired smallpox occurred in 1977, and in 1978. In 1980, smallpox was declared to have been eradicated worldwide after a global campaign of vaccination and containment. It has been 40 or more years since all countries ceased routine smallpox vaccination, as vaccination is also protected against monkeypox in West and Central Africa. Unvaccinated populations are now also more susceptible to monkeypox virus infection. Whereas smallpox no longer occurs naturally, the global health sector remains vigilant in the event it could reappear through natural mechanisms, laboratory accidents, or deliberate release. To ensure global preparedness in the event of the reemergence of smallpox, newer vaccines, diagnostics, and antiviral agents are being developed. These may also now prove useful for the prevention and control of monkeypox. Thanks for watching. For more such informative videos, keep watching Big Bang Bio. Don't forget to like, share and subscribe.